Good morning and welcome back to the National Science Foundation Center for Engineering Mechanobiology Colloquium Series. We're very pleased today to welcome back to Washington University one of our distinguished alumni, Craig Goergen. Craig graduated from our Biomedical Engineering Department in 2005. He was our valedictorian, and he has continued to have a highly distinguished academic career since then. He completed his doctoral work at Stanford, postdoctoral work at Harvard and MGH, and then moved on to start his own lab at Purdue University in West Lafayette. He's been highly successful there. His work is well known, and really his work has set the standard for cardiovascular imaging in mice, and we'll see some of that work today. His work's been recognized by awards as well. He was the 2017 BMES Rita Schaefer Young Investigator Awardee, and his work has been recognized in industry as well, including recognition by Fujifilm Visual Sonics. And he's back in St. Louis. He's been a regular visitor here, and he's going to share with us some of his recent results. Please welcome Craig Goergen.
Thank you, Guy, for the introduction. Really appreciate the chance to present our work here today. My name is Craig Goergen. I'm happy to be here and not only connect with people in St. Louis, but also others as part of the center to learn and tell a little bit more about our imaging work and also connect with people interested in biomechanics and mechanobiology. My lab is focused on cardiovascular disease specifically, and I'll talk today a little bit about our 4D ultrasound imaging work and some photoacoustic efforts as well, specifically using different murine models of cardiac and vascular disease. So first, I'd like to thank the students, postdoctoral fellows, and staff in the lab. These are a great group that has been instrumental for all this work. Really, these are all their efforts that we'll be able to show today and their results. So I'm now more of the spokesperson for a lot of their contributions. So I want to thank them for sure for their efforts. And with that, a quick outline. First, we'll talk about cardiac kinematics and disease, how the heart moves in states of both health and in infarction and hypertrophy. And then also abdominal aortic aneurysms, or AAA, how flow goes through these vessels and expands in cases of pathology, and then how the composition can also be imaged. And finally, some photoacoustic lipid imaging, looking at lipid accumulation in carotid vessels and the aorta, in breast tumor margins, and looking at how to look at composition non-invasively with a light ultrasound combination. So with that, I'll talk about a couple different modalities. First is going to be small animal MRI. And this is a great way to use strong magnetic waves to excite soft tissue, mostly the hydrogen spins. And in this case, this is a time-of-flight magnetic resonance angiography scan in the bottom right here. Allows us to look at vessels clearly, right? We excite blood moving into regions of interest, allowing us to look at the lumen. This is on a 7 Tesla Brooker system, a BioSpec 7030 that has resolution up to 80 microns, so it's great for soft tissue and small vessels. We'll also today talk about small animal ultrasound. So a lot of the work that I'll be presenting was done with the Visual Sonics Vivo 2100 system, this older one, and we've just recently upgraded to the Visual Sonics Vivo 3100 system. The transducers here have center frequencies ranging between 21 and 50 megahertz with axial resolutions all the way down to 30 microns. So very fast, high-resolution imaging systems that are great for looking at motion of vessels and hearts. And finally, at the end, I'll get a little bit into some of our photoacoustic work, where we're using an ultrasound transducer to pick up ultrasound signal that's being created by pulsed laser light from fiber optic cables. So we can deliver light into tissue, excite molecules with a very small amount of energy, cause those to absorb and actually increase in temperature a tiny amount. That creates an ultrasound wave that can be detected with our ultrasound transducer up here, so allowing us to get compositional information as well as geometric. So, conventional ultrasound. On the left, we see the heart. On the right is an aortic aneurysm. You can see the left, the apex is down here on the left, and the base is on the right. So this is the left ventricle of a mouse, which looks a lot like humans. We have 4 chambers, just like rodents. And what we see, though, here is it's a 2D image that only goes down about 1 centimeter. So we need very fast imaging and very high-resolution imaging. Same thing with this aortic aneurysm. This dilation here is a dissection in the suprarenal region. But with this approach, both of these are conventional ultrasound. It's a 2D planar imaging process where we're now looking at complex structures but with just one single image. In the heart, you can do lots of things. You can estimate ejection fraction, stroke volume, cardiac output, or mass, all by using geometric assumptions. This is a Simpson's rule or a Tycholt's approach using these different ellipsoids, where you basically take this complex structure and fit an ellipsoid or a sphere or some other kind of standard geometry to estimate total volume of the ventricle. Same thing happens in the aorta. We can measure diameters easily with a two-dimensional image or with an M-mode approach where we look at 2 points over time. And from there, we can calculate cyclic strain, elastic moduli, or vessel stiffness if we know pressure. But again, it's a two-dimensional image that we're assuming a nice, straight, linear tube within these different regions of the body. And the problem with that is that hearts and vessels are three-dimensional and dynamic, right? They don't form just perfect tubes or perfect circles. There's papillary muscles in the heart, there's trabeculation. In the aorta, there's some curvature, there's natural bending. The motion is off to one side in the rodents as well as humans. And in that case, we need to think about ways to do three-dimensional imaging for these dynamic structures. And that's where we've come into thinking about respiratory and cardiac-gated volumetric ultrasound, or 4D ultrasound. So that's what we're showing here. I'm going to get into that in the next few slides, the details here. So once we have these data, we can do some segmentation. We can look at the ventricle moving throughout the cardiac cycle, right? From end diastole, its max, to peak systole when it's the smallest case. Here you can see how that looks overlaid, peak systole and end diastole. The aorta is up here. The papillary muscles make these really intricate, more dynamic structures that have nothing near the shape of a cylinder or a tube. When we do this now in 6 different animals, these are all healthy, normal mice. We see a lot of variation between animals as well. These are the same age, all male mice, and yet the trabeculation causes much different patterns within the ventricle itself. And so if you take one slice of each of these mice, well, first you have to get the right orientation for each one, and then you have to think about where you're exactly positioning your image to get a true representation of the geometry. Whereas with this approach, we can get true three-dimensional volumes and do segmentation of the ventricle without having to assume anything. So now that we have this data, we want to compare it to both the standard approach, which is a short axis M mode, which is shown up here, where we can take a transducer, put a cursor right across the ventricle, and then track over time the anterior wall, epicardial, and endocardial boundaries. Same thing with the posterior wall. And from there, you can use this Tycholt's or Simpson's method to estimate volumes. We compare that to a 7 Tesla Cine MRI sequence, where if you acquire in short axis, you get fairly good resolution in the plane, very nice visualization of the left ventricle and right ventricle, the papillary muscles coming in here, the septum dividing the two. But in the long axis view, or in your coronal view, the step size is close to 1 millimeter, which is what we need to make the acquisition reasonable. And so that's what we have. The resolution is nowhere near what we would really need for great volumetric reconstruction. So that's where 4D ultrasound really comes into play. You get much nicer segmentations in all these other directions and ability to visualize these complex structures. One thing that's a little interesting is that in ultrasound, you are often used to seeing these short and long axis views, but now we can get coronal views as well. We can see the left ventricle here, how that matches up, but also there's a sternum artifact and some rib cage artifact due to the bone right above the heart that we see, but a much better idea of where the papillary muscles are as they come in and out of these different planes. So some data, quickly I'll show. We compared 4D ultrasound to MRI, took the difference and showed that there's actually fairly good agreement, and much better than what we get when we compare short axis M mode, which tends to overestimate volumes and mass. This led to a couple publications, both in the cardiac work and in some of the vascular space. And what we thought about then is trying to think about the right application for heart disease. And so in coronary work, right, the ischemic heart disease is a big problem. Over 1 million people in the US every year have a heart attack. This is due to plaque buildup within the coronary arteries, and then rupture usually of that plaque leading to thrombosis that blocks blood flow down to anything downstream of that stenosis. And what happens in patients with heart attacks is there's an acute infarction where the cells start undergoing, have ischemic injury and undergo both apoptosis and then eventually necrosis, which then leads to an infarct zone. Thinned out, expanded regions where it's fibrous scar, no longer cardiomyocytes, connecting this part, where the body's natural response is to try to make something very stiff and strong so that the pressures inside the left ventricle don't end up breaking that region. And then finally you get into late remodeling, where now this infarct zone is actually starting to expand and you get spherical dilation of not only the border zone, but remote regions as well, with a lot of increased interstitial collagen even in these healthy sections. And one of the thoughts that others have been thinking about is focusing on the role myofibroblasts play. In a subset of patients that have heart attacks, they have myofibroblasts and collagen synthesis in the infarct area, with it creating a healed infarct that preserves the geometry. You get some change, but overall the ventricle stays about the same size. Whereas in a significant number of other patients, there's a lower number of myofibroblasts, which leads to inadequately healed infarction and severe dilation, leading to infarct expansion in about 20% of patients within 5 years of their heart attack. So that's kind of the thought. We're trying to figure out who's going to go down this normal healing process and who's going to progress to congestive heart failure. So the approach, we want to utilize a non-invasive four-dimensional ultrasound imaging to elucidate some of the mechanical factors that drive this post-infarction remodeling, as well as characterize myocardial strain in vivo. So this is with Arvind Suiprayatna, a graduate student in my group who has done his best to learn the infarction surgery. This means opening up the chest wall in the mouse, putting a tracheal tube in for ventilation, and then trying to identify the coronary artery, which is a small little branch off of the aorta that runs down the anterior portion, and we can now put a ligation there. You can see the heart fluttering away at about 600 beats per minute for mice. You can place a ligation, which then causes a big infarct region in that apical area. And then with that, you get remodeling. So we ended up doing ultrasound on baseline before the surgery, and then days 3, 7, 14, 21, and 28 to get a nice longitudinal data set throughout. And the imaging protocol takes some time, but is fairly simple. We try to make it as easy as possible to duplicate, as well as take any error out of the user of the ultrasound system and need for manual intervention. So the idea is we can use a MATLAB script to communicate with our ultrasound probe. We put the transducer at one specific location midway through the chest wall, and then this three-dimensional stepper motor will move the transducer slowly across the chest to acquire different locations that can then be reconstructed. So from a schematic view, it looks something like this. We can collect one point right here all throughout the cardiac cycle, again from end diastole to peak systole. We can then move the transducer a very small amount and collect a new image in a new location, right? So this is now further up towards the base of the heart, the trabeculation and the papillaries are a little more visible. And we do that again and again until we collect all these data, and then we can reconstruct one specific volume based on where we are in the cardiac cycle, right at the peak of the QRS complex here, a little later, and a little later, till we get all these different volumes that represent all the way from one QRS complex to the next. And we can put those all together in a four-dimensional data set, right? Volumetric, gated information of heart motion. So this is what it looks like when we did a study with 5 mice that had infarcts. And the neat thing here is that, as expected, the sham has nice normal cardiac motion, a lot of typical contraction, not only in the region where we place the suture, but also the apical area as well. Whereas the infarcted mice, 1, 2, 3, 4, and 5 here, the suture causes ischemic injury, but the size and shape of this infarction is drastically different depending on the animal, as well as how that has remodeled over time also varies per animal. So this is why this non-invasive imaging approach is so interesting and helpful, so we can identify per mouse what's happening for each of these. In the case of the permanent ligation model, we've also done not only 3, but a couple times we've gone even further, where we've done day 1, 2, 3, 5, 7, 14, 21, 28 imaging. And so in this case, we get even higher resolution data where we're looking at initial changes, right? There's a small amount of thinning, but not a lot at the beginning. Within the first 7 days, though, you see a pretty substantial change. And then from week 1 through week 4, slow remodeling, that certainly leads to further expansion, but the overall progression is much different and slow at that point. So it's a fast change to begin with and then a slower response overall. So from this, we can get volumes, right? We can look at end diastolic and peak-systolic volumes. This increases for all the animals throughout the 4-week period. But we see that more in these 3 animals than the 2 below, which is expected, right? These were the ones where the infarct was a little bit more severe, leading to further remodeling. We can calculate stroke volume from this data as well, exact stroke volume without having to do any kind of geometric estimation, as well as calculating ejection fraction. Again, the first big drop happens right after surgery, but then slowly, most of these animals continue to go further down with ejection fraction, even in some less than 10%. And these are the ones that we're thinking are on their way to true congestive heart failure and won't last more than a few more weeks. So now that we have these beautiful data sets, we wanted to think about what we can really do with them. That's where we started partnering with John Boyle, Steve Thermopoulos, and Guy Jenin here at WashU. We're thinking about, all right, now we've got information not only at one location or one two-dimensional image, but throughout, right? We've got these beautiful volumes, and there's a rich amount of information you can get from these patterns in the ventricular wall, the speckle patterns, on a reference image compared to the deformed image. So at one point, right, we can grid and then place a kernel and look at the speckle pattern at one location. And with this warping parameter idea and an energy minimization approach, we can use an iterative optimization technique to directly estimate the deformation gradient tensor, and then from there calculate Green-Lagrange strain. So this is what John Boyle helped develop that led to a JBME paper that just came out. It's a direct deformation estimation where we don't need any kind of assumptions, and we can do this now not only in 2 dimensions but in 3D as well, all throughout our volumes. So from an equation standpoint, that's what we're showing here. The warping functions themselves can then be used to estimate the deformation gradient tensor in 3 dimensions, and then from there calculate Green-Lagrange strain using this energy function. So what do these data look like, right? We've got a couple more papers that are in preparation. In the healthy baseline state, we get this beautiful heart where we look at from end diastole to peak systole strains that go from 0 all the way up to 30, 35, sometimes 40%. This is what we typically expect in a normal, healthy left ventricle that's beating and functioning properly. In a mouse that has an infarct, though, right, we don't get that. We see much thinner ventricular region, especially in the apex. The strain is much lower as well. It's this blue that only gets maybe 5 to 10% at some point. So it's very region-specific, but we can get measurements of these principal strain measurements throughout the ventricle, and specifically focus on these regions that are in the infarct as well as the border zone right next to it. So we've been playing around with different ways to visualize this. Again, we focus on principal strain, but we could do different directions as well, longitudinal, radial, circumferential. We're looking at base, mid-papillary, mid-apex, and then all the way down to the apex here in a normal healthy heart, and we get transmural strains here. Again, it's not completely homogeneous, but that would be expected in regions where you have the septum on the left wall here, the lateral wall on the left side of the animal has a little bit higher strain, especially in the mid-apex and lower portions, as well as where the papillaries are coming in or where we see other more complex geometries. After the infarct occurs, though, after 28 days, it's much thinner, the strains go much lower, and we don't see nearly the motion. It was certainly within the apical region, but even further up in the mid-apex and mid-papillaries, the strain values are significantly lower compared to the healthy control. So a comparison now between 0 and 28. At baseline, we have long axis. You can see the thinning as well as how that changes in strain, as well as in the coronal view, right? This is a top-down look. The thickness here is similar in that base, but we get some abnormal strain patterns even in this remote region as well after 28 days. So what can we do to help connect to some of the clinicians that are thinking about strain and looking at human data? Well, the American Heart Association has a diagram, this bullseye map, where it allows us to basically take the heart in this 3 dimensions and lay it out from the apex all the way in the middle here to the base on the outer part, basically unwrapping the heart in a view from the bottom up. This allows us to then look at, with this bullseye map, thickness. So just how thick is the heart? At baseline, it's nice and over 1 millimeter, whereas after 28 days, this thinned out region is what we're defining as the infarct for this animal, right? Which is in that apical region and more in the anterior wall and slightly in the lateral wall as well, which is what you'd expect for the region that's being fed by the left coronary artery of the mouse. Strain, though, then maps up fairly well with this, right? We get strain values of 30, 35% at baseline, whereas after 28 days, the strain values change to much, much lower within the infarct, but also in that border zone nearby. We see lower strain values and suggesting that the region near the infarct is being affected as well. And so This gives us an idea of maybe we can use this strain technique to identify regions of interest, not only for where there's healthy and diseased tissue, but where an infarct might be expanding throughout. So that's kind of the next step. We're looking at these baseline, day 1, day 28. We're processing this data right now to try to get as much information as we can to show how these strain patterns change over time. Whereas with the permanent ligation, right, in the sham, we don't see anything. With a permanent ligation, we see quite a bit, right? This infarct, very thinned out zone to begin with is small. The strain, though, is actually pretty reduced throughout, whereas here you can see the infarct zone is now much larger after 28 days, and again, you see this border zone also being affected. And so we're looking at these strain gradients to see if we can pull some kind of pattern out of there as this progresses, and also look at differences between animals. One final way to view this is more of a surface representation. It allows us to look at the endocardial surface here, basically how the blood is interacting with the ventricular wall. And so even at day 1 after surgery, we see major differences in strain patterns. This is basically in the acute phase where the heart is really undergoing its initial processes, where at day 28, the remodeling is much further along. You get a much bigger ventricle, and that strain is still reduced, but now we get different patterns up in the base. So that's further work for us to identify these strain patterns to see how consistent they are across days as well as throughout the group as well. And this compares well with what we've done with histology. A simple Mason's trichrome stain allows us to identify regions where there's thick collagen, like this here in the left ventricle. The border zone where you get this interconnection between the collagen and the cardiomyocytes, as well as then interstitial collagen in this remote area shown here, where truly by the ventricles you don't see a lot, but further down in this area you see some collagen intermixing, suggesting that that could lead to some of the increased stiffness in this remote zone as well. So a couple quick future work efforts. The student Arvin's done a good job learning the ischemia reperfusion surgery as well, where we tie off the coronary arteries for 30 minutes and then reperfuse, allowing us to look at a more mild form. This is in some ways a better clinical model where we can look at what would happen if you are able to clear a blockage after a short amount of time. So in this case, the ventricle doesn't dilate nearly as much, but you can kind of see this small divot right here. That's the region that we think we've affected through this ischemia reperfusion model, and allows us to look at not only the early time points, but later, that we don't get the same type of massive remodeling as we do with the permanent ligation. So another group that we'll consider. And then some cardiac hypertrophy studies, where this is an interesting model. At baseline, you see normal ventricular motion, where with this knockout of a CPT2 gene, which affects lipid metabolism, a much thicker ventricular wall, especially what we find here in the posterior wall as opposed to the anterior, which is interesting. We always thought hypertrophy would happen everywhere and kind of at the same amount, but this is with Jessie Ellis, who's now at East Carolina University, and her mouse model look at fatty acid oxidation, how that affects cardiac development and then progression from these early stages here where we get normal ventricular motion all the way up to cases where there's now hypertrophy, and then eventually 4 weeks later, true dilation, cardiac dilated myopathy. And that's what we typically see in human patients as well. You go from hypertrophic states to dilated states, and this is where you're much closer to true congestive heart failure. Ejection fractions are much, much lower. So those are some future work areas. A quick summary of the cardiac projects. We have complex geometries. These trabeculation, papillary muscles, and valves mean that we can't just take a 2D approach, as that neglects some of these details. And the 4D imaging is going to provide some exact geometry, dynamic wall motion, and allows us to look at complex cardiac disease models. All right, I'm going to move on to the next. I'm happy to answer questions through email later on if people want to send me comments or questions and connect with people. But I'll also tell you a little bit about our aortic aneurysm imaging project with the 4D approach. So aortic aneurysms are 1.5 times dilation of the abdominal aorta. It's a pathological expansion that can lead to more than 90% mortality if this ruptures. And it's mostly prevalent in the older population. Risk factors include male gender, history of smoking, or just age in general. And the real problem is that we don't know how to treat these. If somebody comes in with a small aneurysm, vascular surgeons will tell them to eat right, exercise, quit smoking, but other than that, there's not much we can do. So right now we wait, watch, and once it reaches a certain criteria and size, then we'd either do open or endovascular surgery to repair the aneurysm. But there's nothing to prevent it to get to that point, and you're always worried that even at smaller aneurysms, sometimes those rupture, and sometimes even larger aneurysms don't rupture, and we don't know which is necessarily the case. So if we can figure out better ways to prevent aneurysm growth, it would help a significant number of people. So with that, we can do this four-dimensional imaging as well. We're thinking about this with a mouse model of mice, where we can look at aortic kinematics, motion, and curvature overall with this volumetric approach, allowing us to get more than the simple two-dimensional information that conventional ultrasound provides. So our lab uses a couple different models, but I'll highlight today work with the angiotensin II model. So this was a suprarenal dissecting model that Alan Daugherty at University of Kentucky developed. And the idea here is you can cause hyperlipidemia in mice through knocking out of the apolipoprotein E gene. And then you implant an osmotic pump that slowly infuses angiotensin II by putting that subcutaneously into the backs of these animals over a 4-week period. And within 3 to 14 days, we get a dissection just above the right renal artery where the medial and adventitial layers separate, and you get this interesting complex lesion that forms in about 60% of these mice. If you do this in 10 animals, 60% will get an aneurysm, about 2 will die from aortic rupture, and another 2 will be completely fine and move on without having any kind of vascular defect. So this is interesting from a clinical standpoint because there's medial degeneration, connection to inflammation, there's a hematoma or thrombus in that intramural layer, and then association with atherosclerosis in some of the branches as well. So what have we done? We've done some time-of-flight MR angiography. Again, this is the process that allows us to look at flowing blood into regions of interest, and we can look at now here the abdominal aorta and the iliac arteries in a mouse. So this is a great way. I mean, these vessels now are much less than 0.5 millimeter and gives us some great resolution. We've done work now where we can see and actually compare then what we're getting with this in vivo MRI data to histology, and it allows us to identify these complex lesions where we see not only a true lumen, but it's shown in an asterisk here, a false lumen as well, where there's flowing blood into these complex regions in a retrograde pattern, very complex swirling locations. And then in some areas, a closed false lumen where there's collagen and some thrombus, some red blood cells that have collected. And we can see that both with the histology and MRI. We've done a 3-dimensional ultrasound approach like I was showing before, showing that both aortic diameter and volume are expanding over time, right? The diameter is what you'd expect, but volume now gives us some more information. We can look at overall volume or volume per length metric, that some of these mice don't just have a simple expansion, but the vessel is growing or expanding as well. So we can kind of pull out some of these differences better with a volumetric assessment. And with ultrasound, we can start looking at how these dissections are formed, not just overall max diameter or volumes, but where the true lumen is, shown here in red, the false lumen, open false lumen in yellow, and then where this intramural thrombus occurs in green. So shown here between the lumen and the adventitial wall, this is all filled with collagen-rich thrombus. And we see that that changes, this overall size and size of the true lumen and false lumen can change between when we first identify the aneurysm as well as then 7 or 14 days later. So some of our other more recent work, we've seen that there's a correlation between aneurysm severity, size, and types of dissections with where they occur and how the branching patterns of these vessels are positioned. This is the celiac, the superior mesenteric, and the right renal arteries. And so if we have those connecting to the dissection, we actually get much more bigger and more severe lesions, whereas the ones that are above or below, usually it's typically above, don't form quite the same size or have the severity or expansion or separation between medial and adventitial layers. So a couple reports have come out on this. We've gotten standard ultrasound with these first studies, and then we've really thinking about how to understand the hemodynamics better, partnered with Jay Humphrey and his group at Yale to build some computational models. And so what we've done here is used our 3-dimensional ultrasound, which gives us great in vivo data, although you can still see it's a little bit noisy and somewhat hard to see sometimes, which then meant we combined it with an ex vivo high-resolution optical coherence tomography approach. It gives us much better resolution, but we're limited in the depth here. We're only about 1 millimeter through the vessel wall. But combining these allows us to then build these very high-fidelity, great computational data sets that allows us to visualize not only the lumen, but the false lumen and the thrombus as well. And from there, we're done some modeling and built these complex 3-dimensional segmentations where we can see simple lesions with just a small expansion all the way up to a multi-lobed, larger dissection that has multiple regions of dissection and separation between the median adventitia and a true separated false lumen in that distal region. So with that, we've taken this image data, we've discretized and created a mesh and used the CEMB Vascular software that Charlie Taylor at Stanford helped develop originally. Well, we measured a flow rate, and from there we did this through a pulse wave Doppler approach, looking at velocities of blood coming into the suprarenal aorta, and then using an RCR, or a Windkessel outlet boundary condition, we're able to simulate computationally blood flow through each of these different lesions. So this is now what we call a mouse-specific simulation, going from ultrasound data with OCT all the way to a CFD approach, or computational fluid dynamic. And this is the type of data that we get, right? You can see here, I'll let the videos play, all the way from diastole, where there's not a lot of flow, through peak systole, where we get a significant amount of flow. In the left animal here, there's uniform one direction, and it's very standard type of flow with shear patterns that you would expect in both normal cases, whereas in this more complex lesion, right, this open area leads to a big drop in velocity, which we can show that leads to a drop in wall shear, as an increase in oscillatory shear as well, and these more complex flow patterns, right? You can think about how this might affect inflammation and where inflammatory cells are localizing, thrombus formation above and below, as well as just how the vessel's reacting to the blood flow through it. So a lot of times, people that are doing the simulation work will get a little bit of information about volumes, maybe a tiny bit of information about the hemodynamics, but because we knew we were going to be doing this, we wanted to really delve into measuring as much as we could with each of these animals. So the inflow matches well, because this is our boundary condition for the inflow, but we actually then did measure flow out of the animals at each of these time points at the celiac artery, the superior mesenteric artery, the right and left renals, and the infrarenal aorta, which is what we see here in black, and averaged over 50 different cycles. We then compare that with the red line. These are the best fit simulation lines of the actual CFD approach, showing that while not perfect, there's fairly good agreement between what we've measured and what we're actually predicting, giving us some confidence in our simulations. With that, then, we can think about vortical structures as well. This is where we've got some mixing and vortices that are forming, especially in these complex lesions over here, where you can think about how that might affect white blood cells or macrophages, neutrophils within the lumen, and how those might be collecting in regions, whereas in the simple lesion, they'll more than likely be moving further downstream or into these branching vessels. Some work we're still in preparation trying to put together is then going not only using what we are able to create from a geometry that actually mimics the condition, but if we basically got rid of all the intramural thrombus, identify where we think thrombus will actually develop. And so that's what this PRT, this prothrombotic residence time metric is showing, where we think thrombus is going to be forming. And that happens even if you then look at where we are predicting a thrombolytic response using time average wall shear stress and oscillatory shear. Calculating this thrombus deposition potential lines up exactly where we actually identify the thrombus in vivo. So again, helping us think about not only how the vessel's expanding, but where thrombus is going to be forming and how that thrombus will be changing for different geometries. We've taken another collaboration where we've taken some of these same data and now not looked at just one time point, but over time. This is with Alison Marson's group at Stanford, where we're looking at velocities not only in the true lumen, but also in the false lumen as well. And really here, the focus is trying to identify how these change, not only between baseline and dissection, but over the dissection process as well. You can see a big shift here at day 5. This false lumen is expanding quite a bit, whereas day 7, thrombus has now started. And that's actually something that other people have reported as well. It's not just a slow linear expansion, but a stepwise process, right? It expands, slows down, thrombus grows again, and then the vessel wall will expand with more of a stepwise, discontinuous approach. So shear stress, we think, will play a factor in that, residence time, and we're going to be looking at not only this one specific data set, but 4 or 5 others to get a full study together. So we've also now done some 4D imaging work. The one caveat with all the simulation work we've done previously is we know these vessels are very stiff, right? There's a lot of collagen, the elastin's broken down, so we've gone with a rigid body assumption where we know that the wall is not going to be moving because we've specifically set that in the simulation. But in reality, we can see that hopefully in this example, in a 40 data acquisition, the thrombus itself is going to be stiff. The collagen inside this aneurysm is not going to be moving very much. But proximal and distal, you still have those elastin lamellar units intact and some nice distensibility, elasticity, pulsatile motion in the proximal descending thoracic aorta, as well as all the way down into the infrarenal aorta as well. So that's kind of the next step, is seeing if we can do some deformable wall simulations. But even before we do that, we've gratefully used the code that Guy and Steve and John had created to do some aneurysm strain measurements. So now this is looking at the luminal boundary at baseline, 2.5, 4.5 days after the osmotic pump implantation. So the dissection's not here. This is not aneurysmal, but we're already starting to see somewhat different strain patterns, maybe a little bit reduced. These animals are hypertensive. They've gotten about a 20 millimeter increase in blood pressure. And beyond that, we're also noticing there's some changes in some of the curvature in some of these animals. So we'll need to see if this is true for not just this one animal, but throughout. But it could be interesting to see that, a dissection is more likely in patients that have tortuous vessels than non. Nobody's really thought about that or looked into that before. So we're going to see if this is a true pattern. But once the dissection occurs, right, now we have separation between the media and adventitia. And actually the lumen shrinks in size here, but the strain is much, much lower, right? This is now all highly rich collagen and elastin that's broken down in this other area on the left side. Other ways to visualize, again, this is just looking at principal strain, but transmurally we can see these complex lumens with open, true, and false lumens. Further down, this area is all now solidified with thrombus formation, this intramural thrombus. Again, very low strains, but then you get higher strains in this distal region further down. So not only the luminal layer, but we can look at strains throughout the medial separation too. Finally, a couple different examples of how we're doing this in relation to the Ang2 model, as well, showing that at baseline there's some heterogeneity certainly, but high overall patterns. And then afterwards, right, we've done more work where now looking at the outer wall, we can see that the adventitial strain seems to be lower within the aneurysm. But if we compare that to the histology, this is exactly where the dissection occurs. So that's exactly where we see collagen, this intramural thrombus formation, these red blood cells coagulating. That's exactly where we see this lower strain. Whereas on the posterior, or the left side, we actually get higher values. So that would fit with where we see this intact elastin units and more pulsatile nature. And so we can actually visualize this on our ultrasound or even MRI, where this side of the vessel, the right side, is pulsating away and moving substantially, whereas the other side is very stiff and not moving pretty much at all. So quickly, a couple other projects in the lab. The Ang2 model is great because a lot of people use it, leads to complex lesions, but it's a dissection model and it happens above the renal arteries, which is actually not common in humans. We've done some work now with an intraluminal thrombus mouse model where using elastase and BAPN, we can create these much larger aneurysms all the way up to 2 months out, where because the vessel is so big, we get such stagnant flow that intraluminal thrombus, not intramural thrombus, but intraluminal thrombus or ILT starts to form. We think this is an exciting approach with a good model to actually measure and identify new therapeutics or gene pathways, because this is exactly what we see in human patients, right? Infrarenal aneurysms where they occur below the renal arteries, where a lot of them are associated with intraluminal thrombus as well. So that's something we can think about, how that affects the hemodynamics, how it affects the smooth muscle cells in the medial layer, or the endothelial cells as well. So a quick summary. The dissecting murine Ang2 AAAs have these really interesting complex geometries. It allows us to look at true and false lumens and thrombus. These are certainly stiffer, although it's heterogeneous, right? But that seems to match with where we're seeing extracellular matrix remodeling. We've partnered with several great groups doing CFD simulations, looking at thrombus and progression, showing that understanding hemodynamics can give us a better sense of what happens inside the vessel. And the 4D gated approach helps us look at wall kinematics that might help us lead to deformable simulations in the future. So I will quickly then move on to the last topic for the talk is a focus on photoacoustic tomography, specifically looking at lipid accumulation in a couple of different models. So photoacoustic is this really interesting approach where we're using light and light energy to create ultrasound signal. So a lot of people in the field will use the first near-infrared window, usually between 600 and 800 nanometers, because you have a drop in very low water absorption at that point and a drop in hemoglobin as well. Whereas what we want to do is actually have gone up to 11 to 1300 in the second near-infrared window, or the first optical window, where you can see here on the green line there's actually a peak at about 1210 nanometers, 1210 nanometers for lipid absorption that we take advantage of to get some lipid signal. If we go down to 1100, that actually is fairly high for hemoglobin, so we can get some blood signal at that. And now going between these two, we can get blood and lipid composition in addition to ultrasound and geometry to identify a whole bunch of different things. So again, for more of the theory behind this, you can send light in and it can absorb at a specific region using this diffuse optical approach. And this only thing we can really try to identify and improve is the amount of light that we can deliver to the specific tissue here. So the photoacoustic pressurized P0, if we can get more light to this specific region of interest, then we can get a better increase in photoacoustic signal due to this greater pressure. So the schematic here is something like this. We have an ultrasound transducer attached to two fiber optic cables. The light can be delivered in, and there's a target that we want. And depending on how we position the fibers, we can go between shallow imaging and more deeper imaging, which is something that we've been trying to optimize through this holder approach I'll get to. But we can go and think about what's ideal for which situation, depending on what we want to look at. So specifics to anybody in the optical field, we use an ND-YAG pumped OPO laser where we can deliver long wavelength, high energy light into these fiber optic cables that are then split here that can be placed on either side of the transducer. We connect that with a pulse generator and connect it to our ultrasound system with a VPAT holder, and then this Stepoco 3-axis control motor allows us to actually change the fiber orientation here. So that's what the 27 photoacoustic paper was about, where it started as a senior design project with a couple undergraduate students that led to a lot of really interesting work developing a better way to combine the fiber optic probe with the ultrasound transducer in a controlled way. Instead of just taping it together and hoping you have about the right area, now this is very controlled, allows us to identify exactly where we want the light delivered and optimize between shallow and deep imaging depending on our applications. Did some Monte Carlo simulations, allowed us to look at, with ray tracing, where the light is delivered. Sure enough, right, you get this nice bell-shaped curve depending on the fiber bundle orientation and the image plane and how much is being delivered. But with rodents, right, they're actually pretty small. So a lot of times we want to do fairly shallow imaging. But we did this first with a PVA, polyvinyl alcohol phantom, with embedded polyethylene 50 PE50 tubing at different depths. You can see the fiber optic cables here changing in orientation. So that, again, is going from a deeper imaging setup. Now, if we want to go more shallow, we change the orientation a little bit at an angle, so now we can deliver light closer up towards the transducer surface. But we can also influence the offset angle here as well with this approach. So, as you'd expect, signal is going to vary with depth. At the 2 millimeter focal depth, we get a really great signal right at the top. Whereas deeper focal depths, you get much more signal and better imaging of these deeper structures. Although it's still not easy to deliver light to these tissue that are sometimes a centimeter or more embedded into PVA or even in a mouse or a human. So this initial work, this photoacoustic delivery mechanism, has also led to some applications in breast cancer imaging and in lipid for atherosclerosis or lipid accumulation. A couple quick examples. So we can do this in a mouse. We can see the abdominal aorta here. This is the skin layer. And so what we realized pretty quickly is there's some subcutaneous fat, even in normal healthy mice, that absorbs at that 1210 wavelength. But you get also a nice view of the perivascular fat right above the aorta, this fat that's located on the adventitial layer. We did some work looking at nerves as well. The lipid within the myelin sheaths, the peripheral nerves, will light up as well for us with the 1210 imaging. And then we can compare that to blood as well. So there's some applications here in surgery, we think, for identifying where nerves are as you're cutting into a patient, and so trying to prevent any kind of paralysis or nerve damage. We've done some ablation work where in cardiac arrhythmias, you can think about trying to damage cardiac muscle, but not knowing from a surface image how far down you've gone. That's where ultrasound and photoacoustic provide some information, right? Pre-ablation, you get these beautiful geometric ultrasound images with no photoacoustic signal. Post-ablation, you get a much more interesting photoacoustic signal that also gives you some depth information as well. Then finally, breast tumor biopsies. We've got a paper looking at if we take lumpectomy tissue out of a patient and identify the hemoglobin-rich cancer tissue and the lipid-rich healthy tissue, we should be able to then identify tumor margins, which it's the 2 to 3 millimeters that you want of healthy tissue surrounding lumpectomy, so that the patient will have a negative margin, we call it. If it's a positive margin where the tumor tissue comes right up to the side of the vessel, or side of the tumor, or the resected tissue, that's suggesting that the patient may still have cancer left in her body and would need to come in for a repeat procedure. So right now, all this tissue is sent off for histology, and the patient doesn't know that cancer was left until days or weeks later, and they have to come in for a repeat procedure. This is an idea we could try to provide information, three-dimensional, non-destructive approach immediately within a few minutes to the surgeon to let them know whether or not they need to go further into the patient or not. But I'm going to focus mostly on atherosclerosis and lipid accumulation within and around vessels. So athero, as I was talking about, is what led to these infarctions originally, but what we see in a lot of humans as well as in ApoE deficient or LDL receptor deficient mice is lipid accumulation just underneath the endothelial layer of the blood vessels in arteries. So there's a couple great models, but the one we've focused on came from Hanjun Zhou's lab at Georgia Tech, where you can take ApoE deficient mice that have high levels of cholesterol, circulating cholesterol, and then feed them a high-fat diet. So basically, this is a lot of cheeseburgers and French fries and things that high in carbohydrates and fat. And from here, what you can do is open up the carotid and expose the carotid. And right now, in a healthy mouse or human, right, you have 4 branches from this: the external and internal carotids, the occipital artery, and the superior thyroid artery. So we ligate 3 of these and leave only the superior thyroid artery, leaving changing this nice uniform pulse wave velocity in one direction, which is what you'd expect in the healthy case, into cases where we get biphasic waveforms, right, in both directions. And this really changes how the endothelial cells experience shear, and then leads to atherosclerosis formation in these mice. So what we have is something like this. At day 0, we get nice, healthy, elastic pulsation, right? The head is to the left, the heart is down here to the right, and you can see the vessel expanding and moving with these bright lines. Where at day 7, we can start to see atherosclerosis formation. So that's what is shown right here, and it's not moving nearly as much, but ather is starting to form. By day 21, that's a lot more apparent. The movies aren't playing quite as well as I'd like, but you can see right here, this little bump into it, and above on the anterior wall is athero formation after about 3 weeks. So at sacrifice, we get something like this. The right carotid is a great control for us. There's really nothing changed there. There's a little bit increase in flow, but the left carotid has all this plaque buildup within the vessel wall in just a few weeks. So our first approach was to just take this vessel out and do some ex vivo imaging. So with gross dissection, you can get some surrounding tissue as well as some perivascular fat, but also then look at what the vessel looks like inside with this approach, right? This is the 1210 nanometer volumetric data set that we've collected from a vibrational photoacoustic imaging approach. And here you can see with this oil red O stain, lipid, right? These little red spots are lipid accumulation inside the vessel at these different locations. So we can do photoacoustic imaging, calculate the signal within the vessel, look at and calculate noise and calculate SNR with the photoacoustic approach. From our histology, we can use an RGB image to then calculate the total cross-sectional area as well as the area specifically of the lipid as stained with this oil red O, allowing us to identify plaque lipid composition, right? How much of this inside is full of lipid versus other components of plaque. And what we found is whether it's male or female, 2, 4, or 6 weeks, there's plaque formation and varying amounts of heterogeneous plaques. But what's interesting now is right? This lines up pretty well that the lipid composition that we see for this mouse here is very high. So there's a lot of lipid, whereas this animal, this male mouse, after 2 weeks was a little bit lower. So there's some heterogeneity in these different groups. But the nice thing about the photoacoustic approach is that there's this great linear relationship between the photoacoustic SNR as well as the plaque lipid composition, an R-squared value of 0.73, suggesting this would allow us to identify where lipid is accumulating. And so now we're working on doing this in vivo and really tracking progression of each individual animal as lipid starts to collect inside the vessel wall over time. Being able to do this in humans would be great, where we could get compositional information on plaque as well as try to think about identifying vulnerable plaque that's at risk for rupturing and creating further stenosis from thrombosis or breaking off and then leading to stroke or further issues downstream. We did do a little bit of in vivo work as well, looking at the aorta, and in this mouse model we realized it's really perivascular fat formation and accumulation. So subcutaneously we see a lot, but also on the walls on the outside and the adventitial. This is the same thing here. You take the vessel out and it stains nice and red because of this perivascular fat formation in these ApoE deficient mice. And so we used the holder actually and thought, well, let's see if we can optimize this. And we realized pretty quickly that these mice are so small that really the best approach was to use the shallow 2 millimeter focused focal length. So that gave us the best signal compared to these other deeper ones. But we then compared the lipid signal, where we get this nice clear view of at least the anterior wall for the lipid accumulation outside the vessel. In the ApoE deficient mice, compare that to wild type, we see a little bit less. Whereas with the hemoglobin, now this allows us to make sure we identify the vessel itself and clearly where the wall is. The hemoglobin signal actually creates kind of a ringing artifact where we get most of the signal at the boundary, the luminal boundary between where the vessel is holding in the blood flow itself. So some compositional information can be, with a MATLAB approach, looking at this perivascular fat thickness. We get a big subcutaneous layer, but then we can try to identify with this thresholding technique just how thick this perivascular fat tissue is. And sure enough, the male mice that are ApoE deficient, that are fed a high-fat diet, have more perivascular fat than younger animals or female animals or wild-type animals, which is what we'd expect. So with that, a quick summary. The photoacoustic approach, we like this adjustable probe holder because it increases the signal-to-noise ratio. We think lipid imaging has got a lot of interesting applications for in vivo, non-invasive assessment. It doesn't need any contrast agent. And we can do this in atherosclerosis, in identifying perivascular fat collection and formation, tumor margin detection, or even fatty liver disease, other things that we've been thinking about as well for in vivo lipid compositional information. So with that, I'd like to leave just a few take-home points. Heart's vessels, they're three-dimensional dynamic, they're heterogeneous, and we think this small animal imaging approach that takes a longitudinal study design allows you to use fewer animals and provide direct three-dimensional measurements. Gives us information on kinematics and strain, can simulate flow from the information that we collect both from a volumetric and hemodynamic standpoint, characterize composition, and is really useful for these complex disease models that mimic human conditions and will hopefully eventually lead to improved patient care. So with that, again, I'd like to acknowledge the lab, Arvin, Freddie, Evan, has just graduated, Gurneet, Alicia, a whole bunch of wonderful graduate students that have made this work possible. Our funding sources from a variety of locations and institutes, as well as my collaborators both at Purdue and externally, several here at WashU as well as at Columbia. And with that, I'm happy to take questions through these my email or website. If you can look up some of our work and have more questions, I'm happy to connect with them.